What if the way we treat vision loss is about to completely change? Gene therapy, light therapy, and next-generation lens implants are pushing eye care into a new era.
Welcome back to part 2 of my conversation with Dr. Chris Wroten. Today, we explore a therapy that's generating serious buzz in eye care. That's red light therapy, and how it may change the way we manage myopia and protect against macular degeneration. Tell us, does that really work? Or, look, these people are very desperate. So I don't want to minimize, even a little bit of vision is better than zero vision for these people. So tell us about Luxturna for labors. Tell us about that, and how much does it really work?
It's a great question. And I can't say I've had a patient personally do it. There's just not a lot of patients with Leber's, hereditary retinal dystrophy and whatnot out there. It's a variant of RP, we think, and at least some would argue it's a variant of retinitis pigmentosa that affects the retina. But it looks like it's about 3,000 patients total. And there may be a few more that come every year with the diagnosis, but we're not talking about a huge group of patients to get a lot of feedback from. So many of us, even in eye care, will probably never have a patient with Leber's in our career because of how rare it is, fortunately. And it's always a question, well, why in the world was that the first FDA-approved gene therapy for any inherited condition? And that's the truth with Luxturna. It was the first FDA-approved gene therapy in all of medicine for any inherited condition. There had been 2 gene therapy approvals for cancers, but there had not been anything approved for an inherited disease process until Luxturna was FDA approved. And so it does appear that it restores some level of sight, both subjectively and objectively, but we're not talking about going from, hand motion vision to 20/20 vision. But there is some level of improvement, and there's media reports in those who've had it done that they can appreciate an improvement in vision, and they would do it again if they had the opportunity to do so. And so, again, anything that we can do to enhance quality of life, I think is beneficial. There haven't been any significant adverse events reported with Luxturna, to my knowledge. But it does have to be delivered subretinally at the moment. And so basically, the needle actually penetrates through the internal limiting membrane underneath the retina, and the DNA material has to be delivered subretinally for it to be taken up. And so, again, we're just trying to get that 11 cis retinal to be produced in the visual cycle that is not being produced currently in patients who have that particular disease. And so gene therapy is all about proteins. If you just want to remember, it's gene therapy is about proteins. We're either trying to make proteins that should be there that aren't. We're trying to stop proteins that are causing disease that we don't want to be there, or we're trying to actually create a new protein that's not native to that patient that may have some therapeutic benefit.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Thanks for making a very complicated subject very easy. So I did see one of the side effects, about 10% of people get a retinal tear, which I thought was interesting.
Yeah, that's not insignificant. Now, we are talking about patients who are having significant vision loss already, so this is certainly not something that we would want to do in a patient who is still seeing fairly well. But for those that have had significant vision loss already, and it's just a side effect of that needle actually penetrating through the retina, like we talked about, where a tear can form as a result of the entry and exit of that needle.
How about genetic screening? There's one for keratoconus. There's been one for macular degeneration that's been around for a long time. But you mentioned in your notes about Natalis as a cheek swab for newborns. That looked pretty interesting. Tell us a little bit about that.
And, some of these have been around for a while, so they're not necessarily new. 23andMe was kind of the first one that was publicly marketed directly to patients. It's added a number of different things that it checks for now, including a variant of AMD, although I think last I saw there were about 54 different genetic variants of AMD, which kind of explains some of the different spectrum of disease that we see with AMD clinically and how it affects some patients significantly and other patients there's not as much of an impact. But the Natalis from SEMA4 was specifically designed for newborns, but it can be done for adults as well. And it currently screens for about 200 conditions. It's a cheek swab, can also be done by a blood draw. So there's different ways to get at it, but it looks at a number of different genetic diseases, and they have a comprehensive vision loss panel that specifically screens for now almost 300 different genes for retinal disease, albinism, ocular albinism, developmental eye diseases, and even the genetic predisposition for certain types of cataracts. And so Natalis is out there. Phosphorus 1 has another one that's very similar. So while 23andMe is more of a generic one that may include a few things here and there with the eyes, we do have a number of them on the market now that have specific vision loss panels for retinal diseases and corneal diseases and cataracts and, just a whole host of things. And so, the question goes back to what you mentioned earlier. Does someone want to know? And when we were talking earlier about Alzheimer's, do they want to know that they have a high risk for Alzheimer's? Well, genetic testing can actually identify those who are at high risk, who carry markers for some of these disease processes. I really like the companies, though, that don't include in their genetic screener disease processes for which there's not an intervention currently available, because there are patients that don't want to know if they've got something, nothing can be done about it. But for those that have something, that there can be an intervention or a lifestyle change now that will reduce their risk of getting these vision-threatening diseases or these systemic diseases that can have some pretty serious outcomes. I do think that there's definitely a number of patients who are very interested in knowing.
And is this something you're doing in your practice, or would it something that you recommend optometrists do, AMD screening, even keratoconus screenings? What do you think?
We saw that keratoconus screening come out a couple of years ago, and unfortunately, the company that brought it to market, Avellino, it was the Avogen test, and it gave us a relative risk for keratoconus. We still don't have all the genetic variants of keratoconus identified, so it would give a pretty high probability of keratoconus. But it also tested for a number of other corneal conditions, and it was definitive for a number of rarer corneal dystrophies that we know we have a good genetic profile for. But the company Avellino began to focus more on their cancer genetic side of things, and they actually mothballed the corneal. They also were in the process of developing a glaucoma panel, a genetic test for glaucoma. And hopefully somebody will buy that license from them and maybe bring that back to us. But there are others that are available. One of the ones we've done the most is for inherited retinal disease. So we mentioned Luxturna early. Spark Therapeutics was the developer of Luxturna. And in the process of developing it, they created a registry for inherited retinal disease. And then there were a number of companies that actually began to fund free inherited retinal disease testing. And so the company has changed a couple times. It's now Blueprint Therapeutics, but they are, as of last month, still offering free genetic testing for anyone who has a family history of an inherited retinal disease, so retinitis pigmentosa, or run down the whole list of those that are out there. And so we have really tried to take advantage of that in our practice while it's free to patients, and give them the opportunity, if we see a retinal disease or inherited retinal disease, or they have a family history of it, we're offering it to them for free so that we can go ahead and get a genetic profile of what exactly their genetics is of the retinal disease, so that if a genetic therapy is approved 5 years from now or 10 years from now, we know that they do or don't have that specific marker or that specific genetic mutation that maybe now there is a treatment available for without having to maybe spend $300 or $400 or $600 or whatever the case may be at the time. So we've taken advantage of that as much as we can in our practice. And the AMD eye guard that's out for AMD is the newest one that I have seen on the market. And again, it is a saliva sample cheek swab type of device. And it's the thing I like about the AMD eye guard, and I have no financial involvement in any of these companies that we're discussing, by the way, just in case there's a question, but the AMD eye guard has two different versions of it. One is for younger patients who are under 55 and have a family history of macular degeneration, but they don't have it now. And we have all been asked by patients, look, my parents have AMD, my mom, my dad, do I need to start AREDS, PreserVision, vitamin supplements? Do I need to do these types of interventions with my diet like my parent is doing who has this? Am I going to get this, Dr. Wroten? And so we all get those questions. And so now there is actually a genetic test that gives them the likelihood of them developing AMD over the course of the rest of their lifetime, based on not just their genetic profile, but I really like that the company includes a lifestyle questionnaire as well. What is your diet? What does your exercise currently look like? Do you smoke? Have you ever smoked? And it takes all of those things and feeds them into an AI algorithm, and it gives you a probability over the course of the rest of your life for getting AMD. So maybe that helps patients wake up more to really change their diet and really change their exercise habits and get more aggressive with supplements and whatnot. And then the second one is for patients who actually have AMD. And so if they're over 55 years old, they've got early to intermediate AMD, not yet advanced or wet AMD, what is their likelihood of progressing to that more advanced form that's even more visually devastating? Again, maybe improving compliance with what we're advising patients to do, with changing their diet and starting some of the supplements and stopping smoking and some of the other things that we know can have a real impact.
And like you said, there's a lot of genetic therapies in the pipeline.
There really are.
So let's turn our attention to something that's very hot in eye care, photobiomodulation. People are very interested in this. I believe Alcon just bought Lumathera,
Yeah.
and so this will probably be something that you'll be seeing in a lot of optometrist offices. But let's start off with myopia. Photobiomodulation for myopia. I saw something that there was something called eye rising, which was a home device where the children would do it, a couple times a day for a while to try to decrease the risk. So does photobiomodulation or red light therapy really help to decrease the progression of myopia?
The studies that were initially published with this all came out of China. And again, they're doing studies and trials on kids who really don't have a true ability to make a determination ethically, morally, whether they want to participate and understand the potential risks that are associated with that. But it's hard to deny what's been published. Now, again, we have to take everything out of China with a grain of salt, but there's no doubt, what patients would do is basically sit and they would look inside of an instrument, and it will expose the eye to a certain wavelength of red light. So on that far end of the visible light spectrum, and they would sit there, they would have a session in the morning. They would have to have at least about a 3-minute session in the morning. They have to have at least a 4-hour break. And then anytime from 4 hours later on, they could do a second 3-minute session of doing nothing more than looking at this wavelength of red light. And we think it's probably simulating what we already know. If patients will just get outdoors more, if they'll spend 90 minutes or more a day outdoors, then we know that myopia is much, much less common. And so we think it's the dopamine release from the sun, and perhaps it's the red light that is causing the dopamine release that tends to reduce axial elongation. But the studies are hard to deny, both in mild myopia and even in high myopia from these studies out of China, that it definitely seems to inhibit axial length elongation as well as spherical equivalent for myopia progression over time. And that all comes again with a caveat. We got to make sure that this is safe for kids. And there have been a couple of reported instances where patients that have undergone this in China even developed a retinal cyst, which is not normal in a pediatric patient. And there was some change in choroidal thickness, actually a thickening, which would be beneficial in some patients, but also there seemed to be some impact on photoreceptor density in a couple of patients that may be negative. And so I think we certainly want to proceed with caution, but boy, I mean, there's a whole field in optometry that's been around for years, Syntonics, that was, just really kind of looked down upon and thought was the fringe. And yet, all of these light therapies, whether it's repeated low-level light therapy for myopia control, whether it's, some of the other devices with the Valeda light system that Lumathera had that Alcon has since purchased, all targeting the mitochondria. And we mentioned that earlier, but NASA was one of the ones that developed the technology that showed, yes, if we exposed cellular tissue to certain wavelengths of light, we can actually enhance mitochondrial activity. And so now reducing, any oxidative species and free radicals that cause damage elsewhere in the body. And so I am excited about the potential that light therapy has. And it's easy to think of it as, well, that's just snake oil. I mean, you're doing nothing more than looking at light. And yet, if we stop for a minute and think about it, what happens when the sun shines on the vegetation outside, right? It triggers photosynthesis, which creates a whole lot of really good things. We talk about lasers. Lasers are nothing more than light that's just, coherent and in phase, and we use that light to actually cause a therapeutic benefit with lasers. And so, is there a way to utilize it in a lower power, in certain wavelengths to create therapeutic benefits? I don't think there's any doubt that that's the case. And you mentioned Valeda and the Lumathera system for macular degeneration. It's the same type of philosophy where basically patients look inside of an instrument that exposes the retina to certain wavelengths of light that seem to actually possibly reduce drusen and slow the progression of macular degeneration. And so I'm really excited. I think more optometrists are going to get access to this now that Alcon has purchased it. Lumathera, that owned it previously, basically made a business decision from the beginning. They were only going to be in retinal specialist offices. And I think that was a little bit of a mistake because, obviously we're the primary eye care providers, and many patients just don't have easy access to that technology. And if it's affordable and makes sense, then it creates another opportunity for us to really, really make a difference in our patients' lives.
When the patient is looking at this, is their eyes open or closed?
My understanding is it's open, and maybe I'm mistaken on this, but I thought it was open. Do you know something different?
I don't. That's why I was
Yeah.
asking. I'm not sure. I've
There,
seen,
there was a technology that did go through the closed eyelid, but unless I'm mistaken, I think this particular one is an open eye care. And again, I may be wrong on that, and maybe some of our listeners can chime in
you know,
with
what's
some comments.
what's interesting about it activates cytochrome C oxidase, which is the final enzyme in making mitochondria, but it also increases nitric oxide, it increases angiogenesis, and it increases VEGF. You're talking about dry macular degeneration. We can't go anywhere near wet macular degeneration because theoretically it can make wet macular degeneration worse, just like it possibly can make cancer worse because you're increasing angiogenesis. Have you got
Yeah.
comment on that?
Well, it's a great point. This is specifically designed for those with dry AMD because there is some pro VEGF components to this. And what might be really interesting to see is if this were combined with some of the new pipeline pharmaceuticals that are coming out that are anti-VEGF topicals. And so, Johns Hopkins and Wilmer Eye Institute has been involved in a study with an eye drop that is an anti-VEGF eye drop that in the initial trials is as effective, if not more so, than our current intravitreal anti-VEGF drop, intravitreal injections, excuse me. So we may have an eye drop that's going to be as effective as the intravitreal anti-VEGF injections, and yet it's a topical medication. And so it may be able to be used in conjunction with something like this so that it counteracts that pro VEGF component of it. And it may actually be a standalone therapy at some point for wet AMD, that eye drop that's in development. So, some really exciting things in the pipeline for sure.
You know, this a lot of optometrists want to use this technology, and they were actually using other devices, which I guess
Yeah.
were not FDA approved, that were off-label, and they were saying they were getting as good a results because they weren't able to use the Lumathera device because of their ridiculous business decision. So I don't know if you know anything about that or any of your colleagues using some other instruments off-label.
I don't have any firsthand experience with it, but I do know anecdotally that a number of colleagues have mentioned that to me as we've discussed this, over the last 2 years or so, and they do report similar results that are reported with the clinical trials for the FDA approval for that delivery system that Lumathera had. So, it's probably not a patented wavelength. I mean, you can't patent a certain wavelength of light. Perhaps you can patent the delivery device itself, or how it's utilized at a certain power. But if the theory is sound, which it sounds like it is, then it could be replicated in other devices.
There's actually somebody who actually, it's not in this country, but they actually have glasses that you wear, and the patient does it at home. And
I've seen that.
that could be much less expensive to
Yeah,
be able to do this type of technology. So it's going to be interesting where this is all going to shake out.
it would be very, very interesting for sure.
I see patients who have cataract surgery in New Jersey where I am, and post-ops. We do a lot of post-ops. And depending on the cataract surgeon, they're on a number of drops from antibiotics to topical antibiotics, to topical steroids, to topical non-steroidals. But now there's dropless cataract surgery. And does that work as well as having the patients on all these different drops and trying to remember when to use the drops? Tell us a little bit about these dropless cataract surgery.
Well, I first heard about this years ago from Rich Mang, one of our colleagues who at the time was in Kentucky, Indiana border within a very large OMD, OD referral practice. And he and his cataract surgeon had kind of pioneered the use of dropless cataract surgery. So basically, after the IOL was inserted in the capsular bag, a cannula was used. It was inserted through the clear cornea incision, and a mixture of triamcinolone and moxifloxacin was essentially squirted retrozonularly into the posterior chamber. And so you had the antibiotic, you had the steroid, is administered in 5 or 10 extra seconds at the end of the cataract procedure. And then patients never used any postoperative medications at all. And so when Rich first had mentioned that to us, I went to our cataract surgeon, and we would utilize it, fairly routinely on patients that we felt were high risk for noncompliance. Maybe it was an elderly patient who lived at home, had arthritis, squeezing a bottle was a challenge, getting the drop in their eye was a challenge. We all know patients struggle with that. And so for our high risk cases, we started doing it, and we had the exact same success that had been reported there in Indiana and Kentucky and in other places across the country. And so I do think it is a legitimate option, and it certainly makes it a whole lot more convenient for patients in the postoperative period. Now, it does create a couple of potential challenges that we can all come up with. We know that steroids can cause IOP spikes, and so if we've got a pressure responder, we've got that steroid that's sitting back there, and we're going to have to do something to lower IOP at least until that steroid is absorbed into the ocular tissue. The other thing with it that we would see, somewhat routinely, that is a little bit of a negative with it, is that the steroids that are injected are all suspensions, so they're not clear, and so it's inevitable that it does tend to get into the visual axis. And so for a couple of weeks after the cataract surgery was performed, we would oftentimes see patients complain of a little bit of blurry vision, and especially for those who are paying some of the premiums now for the premium IOLs. They want to see well right away. And so that was one of the drawbacks to it, was the potential risk for an IOP spike, which we could manage, but then, potentially having to wait a couple of weeks for the steroid to resorb in the eye. Now, perhaps we'll have some steroids that are injectables that come out that aren't suspensions and they're clear, and maybe that could be addressed in that way. But we did see studies published with the dropless cataract surgery that showed tremendous reductions in risk of endophthalmitis and cystoid macular edema, because the medicine is there. We know it's in the eye. It's right next to the tissue. We're not having to penetrate through the cornea and all the other layers of the eye to get it where we want it to go. So it's certainly an option, I think, that's out there for a number of patients.
Patients that go in for cataract surgery, they get this big needle, this retrovolvar block, and now there's medication where they can actually chew this medication, and they would get sedation, or they would get anesthesia, where they don't need to have the retrovolvar block. This could be amazing.
It really is. And so Imprimis Pharmaceuticals is a compounding pharmacy that was started out west originally. Now they have a facility on the East Coast as well, not far from you there in New Jersey. And it was actually founded by a group of ophthalmologists and optometrists to ensure access to Avastin when there was a big issue with compounding pharmacies in neurology. And so the FDA began to more strictly regulate, because of some side effects and issues, some serious side effects and issues that had happened as a result of some compounded medications that were used in neurology. And so they've branched out and done a number of other things now with generics, and have some kind of unique options where essentially, you can get multiple medications in the same bottle. You could get an NSAID, a steroid, and an antibiotic all in the same bottle to use for post-ops for cataracts, for instance, or you could have 4 different glaucoma medications in the same bottle for a patient. So they only use one bottle as opposed to 3 or 4 different bottles. And so that's kind of what their genesis was. And along the way, they developed what's called the MKO conscious sedation melt. So it's midazolam, ketamine, and ondansetron. Ondansetron is there to help with nausea, and then the midazolam and the ketamine give us, sedation and analgesia and a little bit of amnesia too. And it's actually a sublingual melt. So it's one of those little tabs that you just stick under your tongue, and in 15 minutes, you've got the maximum duration of onset of action, I should say. And studies have shown that it, in about 80 to 85% of cataract surgeries, offers enough anesthesia where we don't have to have IV sedation, or we don't have to have a retrobulbar block, and patients can safely and comfortably undergo a cataract procedure. And so, perhaps we'll be able to see that really revolutionize what's involved with cataract surgery. Because if we don't have to do IV sedation, there's some potential advantages cost-wise and in risk to patients when they undergo a cataract procedure.
And is this something that's being used now?
It is. And so there were trials that were done in the Dakotas with this. It's available for sale now. I've seen it as cheap as $25 to $30 per tablet, and usually only one tablet is needed. We've seen it used for other procedures that maybe patients are highly anxious. They have high anxiety. It's difficult for them to sit still and undergo a procedure. And so it can be used outside of cataract surgery as well for any procedure, but it was specifically created for eye care.
And how about this new drop, this very strong drop, the chloroprocaine drop?
Yeah, that's a novel anesthetic that's a topical that's available from Harrow Pharmaceuticals. So Harrow has been around for a while now, and they've purchased a number of traditional ophthalmic medications that have gone generic, and maybe they had been manufacturing had been ceased with those, and they brought them back to us. And one of the new molecules that they have brought is this 3% chloroprocaine gel called IHEZO. That's the brand name for it. And if you've got a Harrow representative and you're an eye care provider, certainly see if you can get in touch with them and get some samples of it to try. But it's a preservative-free vial of this topical anesthetic that is safe to use directly on the surface of the eye. It can be used on the eyelids. We've used it successfully in our practice for chalazion incision and curettage without having to do any infiltrative anesthesia. So it's certainly my favorite of all the topicals. We've used a lot of topical lidocaine over the years for lid procedures and whatnot. And I really do like this 3% chloroprocaine hydrochloride gel. And so that's out there. And again, it's something that the doctor would administer. There is a J code for it, by the way, where it can be passed through to insurance in certain instances. But it's also being tested as a topical anesthetic for cataract surgery. And there are some indication that perhaps we may not even need to do a sublingual melt like the MKO conscious sedation melt. We might be able to use something that's strong enough like this 3% chloroprocaine gel in the majority of cataract surgery procedures without having to do anything further to get adequate anesthesia. And so, again, jury's still out, I think, on that long term, but there's some potential there.
And how about using them both together?
Yeah, even better. Absolutely.
Now, tell me about some of these new microscopes that are being used in surgery. There's actually virtual reality microscopes.
There are, believe it or not, so a lot of the cutting edge cataract surgeons, and I know Lawrence Woodward there in Atlanta, and he's the one who shared this with me initially. A number of surgeons now are not looking through a surgical scope anymore, bending over. It's not a great orthopedic posture per se, but now they'll do surgeries looking at a screen. So the microscope's in front of the patient and they're operating, but they're actually able to be in a much more natural posture, looking straight ahead at a large high definition screen as they're doing their surgical procedure, as opposed to glancing through the oculars of a surgical microscope. And now there's actually a couple of exoscopes that have been FDA approved in the US. Well, basically the surgeon wears a headset. It's an AR, virtual reality or augmented reality type of headset. Some have built-in OCTs, so it basically wherever the surgeon looks in the retina, it will take an OCT scan and it'll pop up on a heads-up display. And so it'll allow them to do surgery even without having to necessarily look at a a monitor or look through the oculars of the surgical scope. And it's got 3D, so it's stereopsis built into it, and I'm sure you could find probably some phenomenal cataract surgeons who are using it routinely, maybe on a future podcast to discuss exactly what that's like. But it allows the surgeon the ability to alter even what light is being shined into the eye during surgery. So traditional white light gives a certain view, but there are some challenges sometimes with seeing the posterior capsule and in the cortex in certain types of cataracts. And so it allows the ability for the surgeon to change it to more of an infrared or an ultraviolet light to further enhance where the capsule is, to increase the accuracy as they do their phaco procedure. And so really interesting to see some of the technology beginning to be available for our cataract surgeons.
I've been watching some of it online and these videos. It's fascinating, just fascinating, and the ones that enhance the visual fields up for the surgeon. Talk a little bit about that one also.
Well, again, it's phenomenal what's out there, and I encourage your listeners certainly to again, you can Google this and find some of these things to actually see some of the differences that it makes. Obviously, as we're looking beyond the visible light spectrum and into infrared, and again, able to just much better visualize the field of the surgery and see, edge to edge from pupil to pupil margin to pupillary margin, and again, even visualizing the retina if there's a concern that something may be going on in the retina during cataract surgery. The surgeon's ability to push a button and activate the OCT and then do a scan as they look up and down, and it pops up on a heads-up display in their headset, and they can actually visualize in real time what's going on in the layers of the retina if there's an issue there. Maybe the patient comes in and they have wet AMD and they're undergoing a cataract surgery. They've got proliferative diabetic retinopathy, or they got diabetic macular edema, and see what's going on and what impact is going on is just really, really exciting.
And the robots are going to be helping us do surgery.
Well, they're already doing it obviously in orthopedics and have been for quite a while in a number of other areas. And I would sit there and say, hey, is it really necessary to use a robotic or a robotic arm to do cataract surgery? And cataract surgery maybe is a little less sensitive to tremors, but every surgeon has some level of tremor in their hands, and we see in a full order of magnitude reduction in tremor when a surgical robotic arm does cataract surgery versus a human arm, even in the steadiest of cataract surgeons. And there's certainly other intraocular surgeries that we know are even more sensitive to tremors, and they're more delicate. So our retinal surgeries, membrane peel, even some of our glaucoma surgeries that we're seeing done. And so, how much will that really impact things if we can eliminate or at least reduce by an order of magnitude the tremor? And so the surgeon's still controlling the joystick, they're still controlling the robotic arm, but the robotic arm is actually doing the work inside of the eye with less tremors. Maybe we'll see reduction in inflammation in cataract surgery, maybe more precision for our toric IOLs and our multifocal IOLs with centration and putting them in exactly the right orientation. And so that's certainly, I think, an area where robotic cataract surgery may actually have a future that I initially may have discounted some.
And for those that are not doctors watching this, after cataract surgery, we take the lens out of the eye, we put an artificial lens in. We call it an IOL or intraocular lens. And the intraocular lenses have been getting better and better and better over the years. Tell us about some of the emerging ones. What are we going to see in the future of these IOLs to help our patients?
Well, it's fairly common for a lot of these to be approved in Europe before they are here in the US. And there's some reasons for that. Some are very valid, making sure that, the lenses deliver on what they promise to patients and that it's safe for that to be in the eye. We've seen a number of things come out in the last decade, and even more recently, like the light adjustable lens, which is a lens implant that can be put in during cataract surgery. And again, for members of the public, the lens that's inside of the eye that begins to get cloudy in all of us if we live long enough, at least at the moment, until we can come up maybe some interventional strategies to prevent that. But that lens is like the lens in a camera, and it's crystal clear at birth in just about everyone, with rare exceptions, and then eventually begins to get cloudy and or cracked on the the inside. And anytime that happens and it's not crystal clear, we call that a cataract. And so we take that lens out during cataract surgery, and our cataract surgeons are so good these days. And then a lens implant is put back in to take the place of that original lens. And the new lens implant, now your glasses prescription or contact lens prescription can be put inside that lens implant, and then that put inside of the eye in an attempt to not only give you clear vision again, but also to reduce your need for glasses and contacts. And the designs that are in those lenses now are getting better and better at restoring the ability to see both far away and up close. Until fairly recently, we were largely restricted with either just setting your vision to see far away or just setting it to see up close. And then you either had to have reading glasses to make up for what you couldn't see up close, or you had to have far away glasses to see to drive. But now there are these designs that do a much better job at allowing us to see both far away and up close. And the light adjustable lens is one where if we take our best estimate of what power to put in that lens implant, we put it in the eye, and after surgery you're not seeing well, we can then alter the power that's in that intraocular lens implant after it's already in your eye, which is something we never had the ability to do. And so there's some designs and things and nuances that continue to develop with further iterations of that light adjustable lens, which are really, really exciting. But things that haven't been FDA approved yet, we've had, trifocal lenses that are working fairly well. We've had some of the extended depth of field lenses that are better than anything we've had before. But there's a lot of shape shifting or shape changing lenses that are in various stages of development. Some are actually already approved in Europe, that either the edge of the IOL has a reservoir in it that's full of a fluid that has a different index of refraction than what's in the central part of the IOL that we look through. And so as the eye attempts to accommodate, which still occurs even in presbyopia, we want to remember, so the muscle pulls on the zonules, the ciliary muscle pulls on those zonules, it pulls and contracts the capsular bag. And so it presses against these reservoirs that are in the off to the side of the IOL, forces the fluid to the center of the IOL, and it's got a different index of refraction, and that fluid also changes the anterior curvature of the IOL's refractive component, and it actually gives an add so that we can see magnified vision at near. And so a number of those are in various stages of development from different companies. It'll be very interesting to see, which one's going to be approved first. There's always the challenge, what if what's inside the reservoir gets out in the eye, and is it going to be toxic, and what impact will that have if there's a leak of that fluid? And so making sure that those are hermetically sealed and it's safe to use long term, I think, are one of the challenges with those. But there's also a number of shape shifters that involve different plates, and so the plates are set apart for your distance vision, but then again, as the muscle contracts, pulls on the capsular bag, you see actually a sliding of these two plates, or at least one plate over the other, that then changes the power of that lens implant to allow us to see up close. And then there's some very fancy designs on the market now that involve liquid crystal display technology, and they're electrically charged. There's a computer chip that's embedded, and there's some expense significantly associated with those. But is there one day an opportunity for us for a fancy computer chip to recognize when the pupil of the eye is constricting, which happens when we look up close, and then sending an electrical current through the optics of that IOL to essentially go from a single vision distance prescription to a single vision near prescription, and what might that look like? But there's at least two different versions of that are in various stages of development as well. And so I think the pipeline is bursting with potential new IOLs that may really be game changers.
I wonder if they'll have where you'll be like binoculars. If you want to see something really far away, you use the computer chip to make it like binoculars for temporarily.
Yeah, I mean, it would be amazing.
Tell me about this laser-induced refractive index change, LYRIC.
Well, LYRIC is out there, and there's another refractive index shape company that also has a version out. And so what we have known for years is that our acrylic IOLs, which is a significant number, they're already in patients' eyes. It would be great to have these new IOLs FDA approved, but then we stop and think about those who've already had cataract surgery, the millions and millions of patients every year that are getting cataract surgery now. It's not easy, again, for members of the public, for our cataract surgeons, as good as they are, it's not always easy for them to go in and take the lens out that's implanted now and put another lens in, because it has to be put anatomically in a different place in the eye that's a little less desirable for us when that happens. And so what if there were a way for us to alter the prescription that's in an acrylic IOL that's already implanted in a patient's eye. And so the femtosecond laser can be used to actually modify the index of refraction that's within the optic section of many IOLs that are on the market. And so in the laboratory, this Lyric and the perfect lens system, which is another variant of what's called refractive index shaping, has initially showed in the lab the ability to take an IOL, expose it to the femtosecond laser through this really thin area of the central part of the IOL, and take a spherical correcting monofocal IOL and turn it into a toric correcting or a toric IOL correcting for astigmatism, again, for our patients who are watching, and take a single vision monofocal IOL and turn it into a multifocal design, an extended depth of field or a trifocal design, and then actually turn it back to the single vision monofocal for distance, all by exposing it to the femtosecond laser, as it is now. And so could there be an opportunity one day for all of those patients that now have an acrylic IOL to come in, sit behind an instrument, and have a doctor modify the refractive power of that IOL to a design that allows them to see far away and up close, whereas what they have now is just a monofocal for either distance only or for up close only, or if they didn't get their astigmatism fully corrected for whatever reason, could we then go in and modify it after the fact and correct the astigmatism? So again, there's a lot to still be developed with that, and I'm sure there's going to be some hurdles with costs and that type of thing moving forward. But again, another technology that's really novel in concept.
It's amazing, and you don't have to open the eye. You can just sit behind
Yeah.
it and do it. But there was something about using this technology for contact lenses. Tell me about that.
Yeah, the Lyric company specifically is looking to see, can we use the femtosecond laser to design a contact lens? So take a contact lens now, it's going to have to be a certain material that will not degrade under the femtosecond laser's energy settings. But can we use it to create an advanced contact lens to do the same thing, to see far away and up close? Our patients get in their 40s and 50s, they start having to wear readers and they want to wear contact lenses, and sometimes it's a challenge. The designs have gotten better and better for sure, but there's still a number of patients that just don't see well enough far away and up close with even some of our multifocal contact lens designs. And so the manufacturers or the developers of this technology on the Lyric side are saying, could we do this with a scleral lens? Could we even take some certain soft contact lens materials and use this laser pattern in such a way that we design on a day-to-day basis contact lenses that give distance and near vision and even that intermediate distance as well? And so I don't know a whole lot about it other than what we've seen in a few media blurbs that they published. Their focus initially is on the IOL market, but they're saying they think they're going to be able to take this same concept and apply it into possibly contact lens manufacture as well.
That would be great for my softball. I'll be able to see the ballpark.
There you go.
That's a wrap on part 2 with Dr. Chris Wroten. In part 3, Dr. Wroten reveals special eye drops that can stop or even reverse cataracts. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.